Cardiology Society of India, 1998-99, and editorial board member of Indian Heart Journal in year 1998-99. She has several awards and accolades for her contribution, like honors with Icon of Cardiology in the World on 4th August in New Delhi, Vidya Shiromani Award 2024 on National Doctors Day on 1st July. Similarly, honors with Icon of the Cardiology in the World Cup 2025 in Delhi, Vaidya Ratna Award in 2024 in Hyderabad, Seva Ratna Award 2022 in Hyderabad, and she has three university gold medals, Pfizer gold medal for best outgoing female student. I thank you, Dr. Tripti ma'am, and welcome you, ma'am, for this meeting. And I hand over the session to you to take this meeting forward. Ma'am, the screen is visible.
Good evening, friends, and good evening, Dr. Amit Saha, for nice introduction. And you have given me this opportunity today to talk about hypertriglyceridemia and the present day consensus and the concept and the utilization. The voice is okay? I am getting some echo there.
Yes, ma'am, it is clear, ma'am.
Clear? Okay, thank you. So, why we should talk about this topic, which is now presently, as we see in our clinical practice, hypertriglyceridemia has become a real challenge for the residual cardiovascular risk reduction, as we see that after aggressive cholesterol reduction, with significant residual risk remains for the people with hypertriglyceridemia, primarily due to the factors beyond the LDL cholesterol control. All of you would agree with me, friends, when you practice in clinical scenario, every day you must be seeing that you are keeping the cholesterol down to LDL cholesterol down to 40 or 50. And then also in primary, secondary prevention, we see hypertriglyceridemia, which is a very important and common risk factor, especially for Indian patients. So that it is important to understand that what is the problem with the hypertriglyceridemia and the two main types of residual risk which are associated with hypertriglyceridemia because of persistently high levels of triglyceride rich lipoproteins, that is TRLS, and remnants of the cholesterol and the residual inflammatory risk, and hence residual cholesterol risk. While the statins effectively lower the LDL cholesterol, they have a less profound effect on the triglycerides. The residual risk associated with the hypertriglyceridemia comes from the presence of the circulating triglyceride rich cholesterol remnants, including very low density lipoprotein and their remnants also. So, what should be
Priti
done?
ma'am, Is the slide moving or it is in the first slide only? Because we cannot see the slide moving.
No, no, 1 minute.
I'm just giving the
Okay,
introduction
I'm
right
sorry,
now.
ma'am. I'm sorry. I'm sorry. I thought maybe the slides are
No, no,
moving.
slide
So
is not
there was one query from Dr. Abhilash also, Abhish also, sir.
sharing screen. Screen is not seen.
No, this is basically the introduction I am giving. Afterwards, we will start the slideshow.
No,
The elevated non-HDL cholesterol also a risk factor, which we see very commonly with the hypertriglyceridemia. And this elevated non-HDL cholesterol levels are better predictor of the cardiovascular disease risk than the LDL cholesterol alone. Hence, even when on target for LDL cholesterol, many patients with hypertriglyceridemia still have the elevated non-HDL cholesterol, and therefore ongoing the risk of remnant cardiovascular residual risk. Atherogenic remnants of the presence of hypertriglyceridemia and high levels of remnant cholesterol contained within the TRLS, that is triglyceride rich in the uh, low cholesterol levels, can penetrate the, I will show all these things in the visuals. This can penetrate the arterial wall and contribute to the plaque formation. The small dense LDL high triglyceride are often associated with the presence of smaller dense and much denser cholesterol and more atherogenic LDL cholesterol particles than without hypertriglyceridemia, which are not captured by the standard LDL cholesterol measurements and the methods to reduce the LDL cholesterol. Then coming to the third residual risk factor, which is the inflammatory risk. And as we know, the triglycerides are highly inflammatory producing, and the inflammation plays a very crucial role in the atherosclerotic and the contributes to the residual risk even after the lipid levels were managed completely. Hence, inflammatory cascade and the hypertriglyceridemia can trigger a systemic inflammatory response with the TRL remnants potentially contributing to the endothelial dysfunction and promoting the inflammation. So, this inflammation comes with elevated high sensitive CRP, which are the markers of the inflammation, such as high sensitivity CRP can produce independently association with an increased risk of cardiovascular events, and this high sensitive CRP levels often persist even after the high risk patients were optimally reducing their LDL cholesterol. That is because of the high triglyceride and its remnants. And this combined risk, all three contributes to the combination of residual cholesterol risk, which causes elevated triglyceride residual inflammatory risk and high CRP risk. So, what should we do now? There are research which are going through quantitative evidence of residual risk reduction, and that is the main result we are going to discuss today in this webinar and in this talk. Hence, I would like to come through the slideshow now. So we are going in stepwise fashion. As I have told you, that high clinical relevance of hypertriglyceridemia, then the use of the triglyceride lowering therapies, what are the clinical scenarios, and the most important, the groundbreaking trial, that was reduce IT trial, which was presented by Dr. Deepak Bhatt, none other than everyone knows in the entire community of cardiovascular disease and their production, that how icosapent ethyl efficacy, safety, and placebo used in the reduced IT trial, which has changed the whole scenario of the treatment of hypertriglyceridemia, and what we currently know about the icosapent ethyl mechanism of action and its production, and how we can prevent the residual risk by knowing all these factors. So friends, we will go one by one. Next slide, clinical relevance of hypertriglyceridemia, as we have discussed already. As we know that there were so many risk reducing factors, and the results were shown by the triglycerides in the different trials, like We had fibrates in the clinical scenario. We had niacin for the triglyceride reduction. But all these triglyceride reduction which were done in the ascent and the different CVD event risk increased dramatically within normal, that is less than 100 to upper normal, more than 150 range. And these trials have shown that 8,068 primary prevention patients in atherosclerosis risk in communities study, that is ARIC study, which is a very famous study for the results of Framingham offspring study, those who were 40 to 65 years old and no CVD risk, but triglyceride measurements on record were 2 plus, and endpoint was time to MI, stroke, or CV death, and follow up for 10 years to first event. And they have seen that CVD events steeply increase across the entire range of triglyceride levels to 200 milligram per deciliter and above, which the relationship is less granted. There is a confidence interval shown that once we have triglyceride levels more than 150 range, this shows regular increase in the morbidity, mortality, and major cardiovascular risk. So this kind of cardiovascular risk, which we are seeing with more than 150 milligram per deciliter, predicts the higher cardiovascular and death and the MI and the primary and secondary points, like we are seeing in the slides, that if there is LDL cholesterol is less than 70 regularly, but still if the only triglyceride is high, that was shown in Prove IT TIMI 22 trial, 4,162 patients, and they have shown that combined morbidity and mortality, death, MI, recurrent ACS patients to atorvastatin 80 milligram or pravastatin 40 milligram, and adjusted for the age, gender, low HDL, smoking, and hypertension, obesity, diabetes, prior statin therapy, prior ACS, peripheral vascular disease, and treatment. And coronary heart disease and hazard ratio was shown in Prove IT and TIMI studies that more than 16% patients had a higher risk for the high triglyceride level as compared to only 11% those who had less triglyceride levels less than 100. So this is the real thought-provoking study by Prove IT that we need to reduce the triglycerides less than 100 by any methods, by lifestyle or by further reduction, by the further improvement in the histopathological conditions, which has been shown that how atherogenicity of triglyceride rich lipoprotein can cause the physiological and the supraphysiological remnants. And as you see this very important picture and the slide, which is showing that how overview of triglyceride metabolism under physiological condition, which is less than 100 milligram per deciliter, can be safe to take. Like suppose we take a high volume of cholesterol in the diet, and it goes straight to the gut, and from the gut it goes to the liver as a chylomicron after absorption and goes to the free fatty acid and CMR, and coming to the liver, it causes the LDL remnants and the low density lipoprotein, which has been absorbed and gone into the B100, and it can circulate into the different areas of the muscle and the fat portions and get absorbed into the liver with the lipoprotein receptors, RPR. So that this kind of normal triglycerides below 100 doesn't cause any pathological conditions, and there is no plaque formation. But now coming to the very serious condition, that is the plaque formation. How it happens? As soon as the LDL cholesterol triglyceride goes above the 150 milligram per deciliter, that is hypertriglyceridemia, then this plaque formation enhances, because the process of LDL adaptation inside the wall, inside the liver and our tissues are not adaptable, and the LDL remnants and the MLDL and the ILDL, that is dense LDL, crosses the vascular wall and produces this high rich macrophage containing the LDL particles, and these macrophages can make a very high lipid core, and this high lipid core can cause lipid enhancing and lipid rich plaques, and these plaques can cause the vascular damage directly by inflammation as well as by the platelet aggregation. So these are the conditions which can cause a high lipid rich plaque formation in the vascular wall with the high triglyceride. This mechanism has been explained very well. So now we know, friends, that we have to reduce this LDL, low LDL. In spite of low LDL, we have to reduce the triglyceride. So what are the triglyceride lowering therapies which are available for us with the evidence based? And when we have got this evidence, that we will discuss. No amount of LDL triglyceride cholesterol reduction by the fibrates, niacin, omega-3, statins or ezetimibe, they do reduce triglyceride to some extent, but there is no outcome benefit in all these trials. If I show you, you can see what are the trials and meta-analysis which we have seen in the randomized trials for the fibrate drugs, and which can show that though in Accord, Field, BIP, HHS, VA, HIT, and in summary, all these triglycerides were more than 200 and they have been reduced, but still with the complementary position of the dyslipidemia subgroup, they have no effect of improvement. But those complementary studies where there were odds ratio show that dyslipidemia was controlled, there was some improvement. That means we have to understand that before we target the triglycerides, we should have the first target for the cholesterol reduction, that is LDL cholesterol. Even the prominent trial also shows that although the levels of triglyceride and VLDL cholesterol, ApoC3 and remnant cholesterol were 26 to 28% lower in the pre-membrane for a fibrate group, but incidence of the CV deaths was not lower as compared to the placebo group. Then what is the reason why we are not targeting the placebo, not targeting the low triglyceride level benefit in all these conditions? So hence, coming to the high triglyceride biomarker of CVD risk. So current non-lipid factors drives the CVD events. Now we know, friends, that not only this triglyceride causing the soft and the bulky plaques inside the blood circulation and the arterial wall, but there is pro-inflammatory milieu, endothelial dysfunction, and impairment of fibrinolysis. So what do we need to have? We need to have low triglyceride as well as all these pleiotropic actions of a drug which can reduce the plaque formation, progression, cholesterol loading, firm cell formation, and that can reduce the triglyceride-rich lipoprotein remnants penetration. So by stabilizing the LPL. So now we come to know that how we can do this expression of the PAI1. All these pleiotropic actions can be reversed by the very miracle molecule, which is the omega-3 fatty acids. And this is being shown in the Eskimos. In the Eskimos, they have shown that lower levels of omega-3 fatty acids in their blood. That is the most remarkable finding, was much lower levels of pre-beta lipoprotein and consequently of plasma triglycerides. And this happened in the Greenland Eskimos because they have shown in the Danish control trials, they have shown, explained very well, that because of their seafood, they have very high rich omega-3, that is icosapentaoic acid in their icosapent in their blood circulation. And there are these studies in the Lancet which were published and which has shown that this kind of high rich seafood has produced very high EPA like substance in there, and which can produce the arachidonic acid activation and reduce it and cause thromboxane inhibition and cause less thrombogenicity and the less plaque formation and the stabilization and anti-inflammatory markers. And they have very low risk for the heart attack. So this has been shown in the JELIS study also. This JELIS study was done in Japan, where they have already high rich in their diet. They have diet full of seafood. In spite of their high rich diet, there was the pure EPA plus statins led to the major coronary events in the hypercholesterolemic patients on statins and in hypertriglyceridemia subgroup. And they have shown that by use of statin plus EPA 1.8 gram per day, they could reduce 19% of the further risk reduction, the major coronary events in next 5 years. And this study included 18,645 Japanese patients. And they have shown this point of care that after 5 years, EPA 1.8 gram per day group had 53% all-cause combined risk reduction. Hence, friends, though this study was positive and there was great benefit of the EPA, but because it was in the Japanese group of patients and they already has high intake of EPA in their diet, it was not cumulated in our clinical practice. And after this, but it has produced a notion and it has shown a pathway that definitely EPA can reduce the risk of further plaque formation and the risk of major primary and secondary endpoints. Then it was modulated and introduced, and it was position making reduce IT trial and icosapent ethyl efficacy and safety with compared to the placebo used was done in 2014 to 2017 by this Deepak L. Bhatt and their group. And this reduction of cardiovascular events with icosapent ethyl intervention trial, which is a major path-breaking trial for this molecule, which is reduce IT trial, which we will discuss in short. And what was the inclusion criteria for the reduce IT? 8,000 plus patients over 45 years with established CVD. That means they already had previous CVD events for secondary prevention cohort. That means they are very high risk patients, more than 50 years with diabetes with 1 plus additional risk factor of CVD for the primary prevention cohort. And fasting triglyceride levels were more than 150 milligram per deciliter to 500 milligram per deciliter. LDL cholesterol was less than 40 milligram to more than 40 to less than 100 milligram. That means these patients were on high intensity statin therapy throughout to make them less vulnerable for the LDL cholesterol risk, but still they had residual risk, and which was proven in this trial. And on stable statin therapy, that is, they had ezetimibe also, and more than 4 weeks of the prior study, they were given all these medication to qualify for the measurements of the randomization. Now, coming to the inclusion for the primary prevention cohort, that was secondary prevention cohort. In primary prevention cohort, they had diabetes mellitus requiring medication, more than 50 years of age, and more than one additional risk factor for CVD, like men 55 years, women 65 years. Cigarette smokers were stopped smoking within 3 months. Hypertension more than 140, systolic or 90, or on antihypertensive medication, and HDL cholesterol less than 40 for men and less than 50 for women. HSCRP, high sensitive C-reactive protein, more than 3 inflammatory marker. Renal dysfunction, creatinine clearance more than 30 and less than 60. And the retinopathy, micro or macroalbuminuria, and ABI less than 0.9 without symptoms of intermittent claudication. So these were all the patients, those who were stage 1, but they were included for the primary prevention. And now coming to the primary composite endpoint after this 5 years of study with the 4 grams of icosapent, that is icosapent ethyl molecule, 4 grams regularly given every day to all the patients, including, and they were double blinded with the real placebo, which was mineral oil. And the CV death, MI, stroke, and coronary revascularization and unstable angina was prevented by positive results for
icosapent
relative
ethyl
risk reduction was 24.8, that means 25%, and uh, absolute risk reduction was 5%. And for one event reduction, you have to use this molecule only for 21. That means NNT is 21. And if you see the p-value, it is remarkable. That is point not 1. This kind of p-value we hardly get for most of our double-blind controlled RCTs. So this is, friends, I can presume and tell you in the clinical practice, though this molecule is very large amount, like 4 grams we have to give, because they have done the study with 1.8 grams, and the other 1 gram trials which are being shown not very beneficial. And the key inclusion criteria as we have seen already, and they have shown the hazard ratio was 20% to 16% in the icosapent ethyl group as compared to placebo 20. So that means we are getting relative risk reduction of 26.4%, not even for the common primary endpoint, but for the CV death, MI, and stroke, which is the major secondary endpoints composite. And there also we got a positive response with very high p-value and relative risk reduction of more than 26%, and the absolute risk reduction of 4%. And this kind of result is very rarely achieved in the RCTs for the clinical scenarios of the risk reduction in major studies. Now, icosapent ethyl lowers the CVD risk, as I have told you, independent on the treatment of triglyceride. That is, whether it was more than or less than 150. In fact, few of the patient had triglyceride 100 also. And there also we got equal amount of risk reduction in spite of not too high triglyceride. That means if triglycerides are even 100 to 150, then also icosapent ethyl 4 gram per day can produce this much of risk reduction which you are seeing in your screens. And this is known as the reference to statin placebo and the statin IP and the statin plus IP triglyceride reduction. You can see the how amazing the results would be. The adverse events for interest of the bleeding and other things in compared to placebo and the p-value, which was not at all positive, they are equal, and any bleeding with possible fatal association were not there, and very minor bleeding has been shown, not even contributing to the p-value. Now coming to adverse events of interest like atrial fibrillation and flutter, and we see that this positively educated AF and atrial fibrillation and flutter, which requires 24 hours hospitalization, were much less in IP group as compared to placebo, and this efficacy has been shown and were educated to efficacy endpoint. All other atrial fibrillation flutter events reside in the safety database. And coming to primary key secondary endpoints by history of AF, you can see that this also shows that icosapent ethyl is better as compared to the placebo for the prevention of recurrent AF events and the hospitalization for AF events. Now, the placebo was mineral oil, which was annualized event rate in reduced IET trial, similar to the control group event rate from the cholesterol treatment trialist,
icosapent
that is
ethyl
CTT collaboration with meta-analysis. And now we know that in spite of annual event rates were higher in the higher risk populations, that is statin versus control, when 5-year risk was more than 20%, this has reduced the more risk, the more better result with the icosapent, that is intensity of statin when 5 years risk was reduced more than 20%, and there also we have got the better results. So this mineral oil statin absorption and robust CV risk reduction irrespective of LDL cholesterol levels has shown that in spite of compared to icosapent ethyl, there was no difference in the outcome for placebo patients with increased or decreased or no change in LDL cholesterol at 1 year follow-up. That means in spite of no change in
icosapent
LDL,
ethyl
there was a risk reduction. That means it was the mechanism of action was not because of LDL reduction. The mechanism of action was pleiotropic. and they have seen a robust CV risk reduction by irrespective of HSCRP levels. So compared to icosapent there was no difference in the outcomes for placebo patients with increase or decrease or no change in HSCRP at 2 years follow-up levels. That means the placebo didn't cause any increase in the HSCRP, which was a cause for debate after the strength trial. So now absolute change in the biomarkers, if you see, there was no change associated with CV risk and the baseline and the LPA, if you see lipoprotein little a, which is the risk profiler for the genetic condition, and that was less than 30 milligram per deciliter normal, and which has not produced any further increase, and IL-6 picogram per ml and IL-1B, which are inflammatory markers, that has been shown in two groups. Between the groups, the difference was not significant. Hence, these are the factors which we have shown that subgroup from the reduced IT deriving benefit from the icosapent with all the subgroups, including prior MI, prior PCI, prior CABG, post ACS, heart failure, chronic kidney disease, cigarette smokers, metabolic risk, anything. We have seen the reduction in the risk profiling. Hence, with confidence now, this is the confidence we have gained after reduced IT trial to use 4 grams of icosapent regularly for 5 years to get the reduction, and within 1 year we get the benefit, and within 6 months the first event prevention. Now coming to a very interesting trial which has been shown that not only clinical events reduction but the intravascular imaging wise also we have seen, that is evaporate study, the effect of EPA on improving the coronary atherosclerosis in the people with the high triglycerides taking statin therapy. And there also it has been shown that easily it has been shown that we can reduce the risk of atherosclerotic plaque development, progression and regression. So this is a randomized double-blind, very interesting study, and which shows the population was 30 to 85 years age. Triglyceride levels were from 135 to 500, and LDL was less than 40. And on statin and angiographic stenosis with more than 20% narrowing by coronary CT angio. No history of MI, stroke, or life-threatening arrhythmias within the prior 6 months, and no history of CABG. The primary endpoint was progression rate of low attenuation plaque, and secondary endpoint was plaque morphology and composition, makers of inflammation, LPA, PLA2, and LDL cholesterol and HDL cholesterol. And it has been shown that by 18 months of EPA 4 gram per daily compared to placebo, for 18 months, the evaporate study seeks to determine whether IPE 4 gram per day will result in a greater change from the baseline in plaque volume measured by serial multi-detector computed tomography than placebo or statin treated patients. And you will be surprised to see that how this has reduced the plaque burden, icosapent and the low attenuation plaque burden and the fibrous plaque, the calcification and the non-calcified plaque and total plaque burden was reduced by from 21% to 57%. Only in the fibrofatty plaque, which was the rich plaque, was reduced only by 19%, which is not statistically significant. But all other types of plaque in 9 months was significantly reduced, as you can see in this CT angiogram diagram, where they have shown in the left side, that is right coronary artery, where there is a large FFR positive, the red and orange large, and after 9 months of the study period, you can see it has become green. The FFR has reduced, that means plaque burden has come down, and the critical lesion which you can see in the right coronary in the mid segment is reduced, and it has become now almost normal segment. Previously it was almost 70-80% block, and now after 9 months it has become less than 50-60%, and the FFR has improved and it has become significantly good FFR. On the left side, on the right side, if you see now, the circumflex artery, where there is FFR was positive initially, and after 9 months to 18 months of this study drug, the FFR has become negative. And now coming to the mechanistic clues to omega-3 fatty acid CV benefits, focus on the coronary plaque regression and stabilization. So how does it happen? Now quantitative coronary angiography also have shown, there are studies where they have shown EPA ratio had relationship with the progression of atherosclerosis, and highest quartile of EPA ratio had a very significant higher risk of progression from the lowest quartile. Now if you see EPA statin, where the LDL was reduced and the statin was given, the diameter stenosis change you can see so much. Normally the diameter stenosis change will not come only with the statin. That means 1.6 diameter stenosis was there, but when you have included EPA, it has come down to minus diameter stenosis, means so much of improvement in the diameter stenosis by the EPA. And this was shown in the 1.8 grams added to statin therapy to reduce the lipid volume. And the next I will show you the Cherry Ivor study. This study is randomized, non-blinded, parallel group, multi-center study, which has shown with the pitavastatin 4 gram and the primary outcome 6 to 8 months. And after the use of this thing, the EPA, the amount of baseline to follow up, there is a significant reduction in the intravascular evaluation of the plaque. Now, IVAS, EPA and pitavastatin significantly increase the coronary plaque regression versus pitavastatin. You can say the p-value is 0.001 and more than 50% reduction in the plaque volume. The 200 CHD patients underwent PCI and were randomized to EPA4 plus minus pitavastatin, and coronary plaque volume and composition in non-stented lesions were analyzed by integrated backscatter intravascular ultrasonography at baseline and 6 to 8 months follow-up. Now you can see this OCT criteria of EPA plus statin, which has shown that thin fibromatous plaque and the thick plaque, 30 patients have been taken. The fibrous cap thickness and the length was studied, and change in the optical coherence tomography parameters were shown. And this has shown that with untreated dyslipidemia were randomly assigned to EPA and rosuvastatin, and they have shown 49 non-culprit thin cap fibroadenoma lesions were analyzed at baseline and at 9 months. And at 9 months, you see the thin cap has become fibrous and it has improvement in the effect of rosuvastatin and icosapent acid on non-atherosclerotic, the LINK IT trial showing the same thing, 37% macrophage grade, and which has reduced now from negative to positive 35.3% and p-value 0.001. And this has been shown in the serial CT angiography also to assess the plaque progression. And now this plaque progression has been shown to be reducing with the use of icosapent. So this clinical effect of EPA on the atherosclerosis plaque by imaging modality and multi-detector raw computer tomography MDCT has shown that when the change in plaque quantity based on the treatment group, you can see that how evaporate final trial, this is showing that 109%, 32%, all these are reduction by the fibrofatty fibrous and calcification and non-calcified total plaques. And this is the same amount of plaque reduction which we have already discussed. And now coming to another study, that is RESPECT EPA trial design, and it has shown that highly purified EPA, that is icosapent ethyl, in the cardiovascular risk reduction in Japanese, and this is second trial. First JELIS trial was positive trial, and now they have shown that in this trial, which is RESPECT EP trial, when they have used purified EPA, then there is a positive result. But when they have not used purified EPA, and that was a mixed, that is strength trial design, where there was EPA plus DHA, then the result was not good. They have shown there was no benefit in such a large trial, 14,000. and they stopped the trial in between because the DHA was causing increase in the risk of plaque burden, and the secondary and primary endpoints were not beneficial with the this trial. And why it has happened? Now they have analyzed that EPA versus DHA, structurally they were similar, but functionally they were different, and there were some links which were more in the docoso DHA, which has shown that there is a small structural difference can give a large biological difference in the outcome. So that this is the mechanistic action of the EPA as compared to DHA. And this EPA has preserved the membrane structure and normal distribution of cholesterol, inhibits the lipid oxidation and related to cholesterol crystal formation, and influences the signal transcription pathways related to the inflammation and vasodilatation. This is the beautiful action of the EPA, which causes the membrane stabilization and the anti-inflammatory action, and the preserves the membrane, and that incorporates in the phospholipid at the SN2 position. Now, what happens with the DHA? Now, if you look at the DHA, it has got incorporated in phospholipid at SN2 position, and it has got different increase in the mechanistic actions of the inflammation and increases the membrane fluidity, and that has caused the more plaque burden and the more composite endpoints. The DHA has reduced the antioxidant activity due to lipid disordering effects and is concentrated in the brain and retinal membranes. Hence, friends, DHA is not good, and we have been seeing this combination has been detrimental. Hence, we should not use DHA. We should use pure and very purified EPA, and which was used in the reduced IT trial. And this only EPA is anti-atherogenic versus the DHA. Now you can see this diagram where there is very clearly it has shown that how it is anti-atherogenic by raising the LDL in patients with very high triglyceride, reduces HSCRP, that is inflammation, maintains the membrane cholesterol distribution, and preserves the membrane stability, inhibits the cholesterol domains, and enhances the endothelial function with statin, and inhibits the small dense LDL, which are the lethal LDL particles, and the oxidation, and enhances the ABCA plus cholesterol efflux. This is all the fibrates. They have only two action. You can see that reduces SHCRP partially, and that is all. And DHA has got mostly no action. EPA is the only one which wins in this race and reduces the. So this is the all mechanism of action about icosapent ethyl. We have actions we have seen, and we have seen all these actions, that how it acts by endothelial dysfunction reduction and cell damage reduction, plaque vulnerability reduction, ischemic event reduction, and increase in the HDL and cholesterol crystals and inflammation. And now coming to EPA-induced anti-inflammatory transcriptome in T cell, and this is the mechanism by transcriptome in the T cell mechanism. It can reduce the anti-inflammation, that is exposed non-activated CD4 T cell to 100 micron EPA, oleic acid, palmitic acid, or control, and conducted RNA and ATAC sequencing after 48 hours. They have shown that EPA exposure down-regulated the immune response, and transcription factor footprinting showed decreased GAT-A3 and PU1, and increased REV and the ERB. These effects were specific to EPA, suggesting it induces real membrane stabilization and anti-atherogenic activity. The same thing again, protein expression and bioavailability of nitric oxide has been shown in the endothelial membrane of the use with the EPA. And this again, IPA modulates the circulating vascular regenerative cell content. See, you can see the how it can cause the observe that IPA treatment for 3 months increase the content of the progenitor cell with critical roles in the vessel repair and reduce cellular oxidation stress content. So friends, now we have understood the entire mechanism of the EPA. Hence, ACC 2021 expert consensus decision pathway on the management of ASCVD risk reduction in the patients with persistent hypertriglyceridemia has come up With this consensus, friends, if you have an adult with ASCVD and fasting triglyceride more than 150 and non-fasting more than 175, triglyceride up to 500, the rule out secondary causes, then optimize diet and lifestyle, optimize glycemic control, maximize statin therapy, preferably high intensity statin, and optimize statin adherence. Persistent fasting hypertriglyceridemia remains after these lifestyle and the other mechanisms, then you can rule out secondary causes and further optimize lifestyle, and may add icosapent in this condition where the triglyceride is not reduced to below 150. The shared decision making patient preferences you have to check and combine the risk prevention and use the consider using the icosapent, and all these conditions will improve further by using the icosapent, as we have seen 25%
Support.
reduction in the further this thing future in the 5 years follow-up studies. And now this proposed synergistics and enhanced MOA of IP and statins, which we have already discussed, and this was the consensus in October 2021 and September 2021. They have given this consensus that once we have seen this kind of scenario, we have to add EPA, which is the most purified form, 4 grams of icosapent. Now coming to a case which we see almost daily, where a 74-year-old woman had a non-cardioembolic stroke treated with thrombolysis 3 months ago and no neurological sequelae, otherwise well, has private drug coverage. And clopidogrel, perindopril, atorvastatin, all in full dose has been given, and well-controlled cholesterol. What would be our next step regarding her lipid management? That is, her triglyceride is 195 milligram per deciliter, although the LDL cholesterol is reduced to almost less than 100. So what we can do, she is on very high statins already. So what we should do in the next step regarding her lipid management, reinforce the diet, add azitamide 10 mg, add evolocumab 140 milligram Q because of the LDL cholesterol risk, which is 93, and add icosapent ethyl 2 grams BID, that is 4 grams daily, add ezetimibe 10 milligram OD plus icosapent ethyl 2 grams BID, add evolocumab 140 milligram twice a week for once in 2 weeks. And this kind of treatment approach is the present day scenario where even the residual highest risk patients also, we can prevent the further occurrence of the cardiovascular major and minor and the composite events, and make the life much longer with the less intensity, less happening of the CVA, stroke, cardiovascular, renal, everything can be prevented with this kind of understanding, with the exhaustive results of these trials. I would conclude now with my friends' agreement that there remains a significant residual risk in our cardiovascular patients despite good control of LDL and traditional risk factors. In reduced IT trial, IP 4 gram per day significantly reduced the risk and subsequent CV events, including stroke in patients with pre-existing ASCVD or high-risk diabetes. Similar benefits have not been seen in trials utilizing other omega-3 fatty acids because they had combination of DHA, likely as a result of specific effect of EPA on the vasculature. New guidelines emphasize the potential benefit of IPE in the appropriate patients, as we have discussed. Hence, finally, IPE has many beneficial effects within the cardiovascular disease continuum, induces anti-inflammatory transcriptome in the T cells, improves endothelial nitric oxide bioavailability, increases circulating vascular regenerative cell content. Hence, EPA only, that is no DHA, should be used. The effectiveness of pure IPA on the reduction of CV events is independent of triglyceride lowering, that is pleiotropic action. I am so thankful to all of you to given this time in the Sunday evening and given me this opportunity to go through in details about such a wonderful and unique molecule which we should use for our regular basis for all our patients wherever we find. And in Indian scenario, as we know, the triglyceride levels are higher, more than 60-70% of our patients. Mostly we find them very vulnerable to all these events. Thank you so much for kind hearing. I am here to answer the questions also. Thank you.
Dr. Tripti ma'am, it was a great presentation. There were a few questions from the doctors in the messages. I would like to read it out to you, ma'am. We
Yes,
have
yes.
Dr. Sharad Jain. He is asking about atherosclerosis process starts after childbirth and progression and progresses with the increasing age. What is the age the evaluation and treatment should be started?
This kind of question is very important in Indian scenario, because we are seeing now that the our what is the IP that Indian Lipid Association ILA says that when there is a family history of high risk cholesterol in the family history, like patients parents, grandparents are second generation, and they have a high LPA levels. So we should check our children at the age of 2 years for first LPA detection and first cholesterol evaluation. And if it is for a 2 years old child, if it is more than 200 total cholesterol, not L, LDL cholesterol and LPA more than 30, then these children should be taken in a primary prevention model for the strict lifestyle modification and very good dietary control and their physical activity control. And after the control of all these things, after 5 years, that is at the age of 10 years, we should check the next cholesterol level. And triglycerides should be maintained first initially, because triglycerides are not only for the vascular injury, but they are for the development purposes also. They in our children during developing ages, we should not give these molecules immediately unless until they have heterogeneous or homogeneous triglyceridemia. For homogeneous for homogeneous lipid, not triglycerides, we have to use the drugs, depends upon the levels and depends upon the pediatric association cardiology their guidelines. So this is what we should follow for the children. And those who have real family history, they should be regularly followed every 5 years, every 2 years with their lipids. And the LDL cholesterol is mandatorily kept below 50 or below 70, even for the growing children, also to prevent the further occurrence of atherosclerotic plaques. Thank you, Dr. Sharad, for asking this question.
There is another question from Dr. Sharad itself. Your suggestion about omega-3 from flaxseed and omega-3 from red algae role in cardiac pathology.
Yes, Dr. Sharath, it is a very good question, because there are so many over-the-counter omega-3 drugs available, plenty, but none of them they have shown the real cardiovascular benefit for the long-term use. Hence, they are not beneficial too much as we see in the clinical scenario and the studies. And the only study which has really shown with the very great p-value, that is reduce IT, and which is used very pure EPA, that is icosapent only, nothing else, no other combinations. Hence, I would suggest that we should go with the very pure EPA, which is produced by commercially produced by purity, and there should not be any impurity and any combinations for these conditions to really reduce the risk, further risk reduction.
So another question is from Dr. Sharad itself. Triglycerides are reduced from fenofibrate 160 mg. How do you see the benefit of triglycerides in cardiac atherosclerosis?
Actually, fenofibrates are more dangerous because that increases uric acid inflammation, that increases LDL also. The fenofibrates are not to be used actually. They are contraindicated. Actually, FDA has totally removed fenofibrate actually from the our pharmacological armamentarium. That is a banned drug actually, but still in India we are getting, because no amount of triglyceride reduction by fenofibrate is beneficial. It is always harmful only.
There
So
is a
we don't
comment
recommend
from
that.
Dr. H.S. Arora, sir. He is talking about in market omega-3 is sold uh, locally from fish of India, we should be avoid to take it because of huge mercury in it. Any comments, ma'am, on this?
Yes, yes, Dr. Arora, you are very, very correct because so many over the counter omega 3 names are there, but they are totally not pure. And there is lot of impurities, and like you said, mercury is one of them. There may be lot of impurities. So we need not use those conditions, and only FDA has approved only this one only, icosapent, EPA, not any other omega 3, that too highly purified EPA. Because if you go through the other studies like strength study, other study, where they have not used highly purified omega 3, and there the results were not good. So we know now that since Reduce IT has used highly, and that too 4 grams, if you use only 1 gram or 2 gram, the level of omega 3 EPA in the blood is less, and then we don't get the beneficial effect. So we should have a therapeutic level in the blood of omega 3 with the highly pure EPA. Then only it will be beneficial to the human body. So that is what FDA has approved, only EPA by the Reduce IT trial what they have used.
So the forum is open for questions. If anybody has questions, we can post it, or maybe you can ask directly to my.
Hello.
Seema, I can see
Yes,
you.
sir.
Hi, Seema. Dr. Seema.
Hi.
Hello, Dr. Arora.
I want to say something. It is little interesting. After, during long COVID protocol, I saw a few cases which were, put under surgical treatment due to reasons were there. One thing was very important. Lot of blood vessels, which were major vessels, smaller vessels. If you all know, there is something known as a vasa vasorum, which is a vessel of vessels. These are even smaller than capillaries. They supply the endothelial as well as with the muscular layer of the blood vessel. Due to long COVID inflammation, the patient had developed huge inflammation in the endothelium, resulting into formation of thrombus formation in different areas. And there was a huge collection of calcium deposited, which was also then further identified. It had a huge amount of TG as well as LDL into that. And one of the doctor, I won't name him, he used omega 3, which was not from India, but that time, and the dramatic changes took place in those patients. There were only 6 patients. There may be large number of them. And why he had called me, because we had worked together in armed forces. So he asked me, I want your view. So it was very interesting. In inflammatory changes in blood vessels, which are called vessels of the vessels or vasa vasorum, or the vessel which supplies the major blood vessels of the body, brain, heart, and you name every part of the body, you will find these changes due to inflammation. Thank you.
Thank you, sir. Thank you for your nice this thing. Actually, during COVID time, I don't know whether we checked the triglyceride that frequently because we were more worried about the other things. And of course,
Yes,
thrombogenicity was at its peak, and
very high.
most of the patients were dying de novo thrombus, the vasculitis
Yes,
we call it, horrible
yeah,
vas. So we had to give direct antithrombin, like direct
correct.
thrombin inhibitor, like heparin infusions full, or we have
Mhm.
given thrombolysis also even in that conditions. So even NOACs were not working. So you are right, sir, in that way. Seema, you want to ask any question, Dr. Seema?
It's an eye-opening, actually.
What is
Later,
your
I'll
triglyceride, Seema, if you don't mind?
I don't have in my hand, but it has increased. It is
Yeah, you
increased.
take care. Take
I'll
care of
give
it.
you.
Of
I
course.
don't have. It's more.
Yeah.
So you have to help me for that.
Yeah, of course, of course. You
Yes.
send me, I'll send you the
Yes.
prescription, then you can take prescription
Yes. Yes.
dosage. Yeah.
That's what we are doing since 2 years.
Yeah.
No.
Yeah.
Yeah.
Thank you, Dr. Seema, for coming and spending your time.
Every webinar, I want
Thank
to
you.
be with you.
Thank you, Sharad, and thank you, everyone, one and all, for coming and joining. It's well for me also, since I reviewed the literature in details and went through everything in details. In fact, I also got so many new insights for this kind of conditions which we see in our day-to-day practice. So now onwards, I have started giving this ecosapent highly purified
Thank
IPS
you,
for
Tripti. Very
my
nice.
patients.
Best presentation. Most
Thank you, thank
informative,
you,
useful.
thank you, Sharad.
Okay, bye.
Thank you. Bye.
Excellent
Take care.
presentation and a great information to everyone.
Thank you.
Thank you, Dr. Tripti, ma'am.
Thank you,
Thank
sir.
you, all the
Thank you.
doctors, for joining us tonight. And it was a great session. I think just wanted to say a few words about BDR Pharma. We are the sole manufacturer for icosapent and dithyl in India. We not only produce in India, we export to US and other countries. We are known for our oncology as well as critical care formulations. We are known in oncology segment because of our quality. So in that sense, because icosapent ethyl was our own manufacture, we thought to come into the market and we wanted to see that this particular molecule, which is having a huge potential to grow up. So I think we would be coming back to you. Our team will be coming back to you with our icosapent ethyl. The brand name is ISAP, which is available most of the places. So I think thank you very much for spending time on this Sunday evening. I think thank you very much. Have
I
a great
want,
day.
I have one question.
Yes, sir.
Sir,
Yes, sir.
what is the source of this icosapent?
So, sir, as per Reduce It,
Is
there is
it
4 grams.
any chemical source or
No, it is a marine
some
source. It's a marine
very
source.
source?
Marine source. And it is a highly purified icosapent ethyl, and it is
Uh,
approved in India. We are the company which has got an approval from DCGI for manufacturing and marketing it. And we are giving two other companies which are marketing it, sir.
Actually, Tripti has given me those capsules. So I said it is a non-vegetarian source. I'll not accept it. She has
So it's
given
a
me.
purely marine source, sir, because
No,
nature has produced and we cannot actually change it to chemicals. So it is even
no, actually,
some days back.
what I learned from the literature that there is a red algae in the marine source, and these salmon fish, and they consume maximum that particular red algae, and they derive omega 3 from that source only, and that you extract from, I think, from the particular salmon fish oil.
So as of I know, it is marine, but is it fish or it is algae? That I have to come back to you, sir. But
I tell you, it is
so, but
out of subject, but definitely the source is red algae.
yeah.
He is prepared making this omega 3. And now the question is, if it is a non-vegetarian source, then many people may not prefer to take.
I
The
definitely
human
understand,
body
sir.
consumes vegetarian and non-vegetarian.
Uh,
It's a if a person says ki I don't take non-veg, he must understand we the human being, we take vegetarian, we take non-vegetarian, amount of microorganism we inhale through
is,
all means. So they are
is,
not non-vegetarian.
देखिए,
Abhi, I had
all
worked with
all the
NASA.
customary,
I had, I
Arora
had
Sahab,
worked.
it is a
हाँ,
customary. Uh,
कुछ नहीं है ऐसा.
you cannot go beyond your customs. That is the basic idea. You cannot challenge anybody's customs.
Yeah, that's there.
Okay.
It's a
That is
belief of
okay.
person.
Sure,
Thank
sir.
you.
Thank you very much, sir. And sir, our team will be also coming to you. We would need your hand holding. We will need your guidance because we have just come in. and we are trying to make a mark with hypertriglyceridemia, because if you see, sir, at this point of time, ACC has given 2B recommendation to icosapent. But as soon as this next year ACC guidelines is coming, it is going to be upgraded to 2A. So because we were been talking to Dr. Michael Miller, and he was talking, because this ESC, there was a talk on icosapent on CKM, cardiometabolic syndrome. So in that sense, there is a lot of talk which is going on icosapent, and there will be a lot of upgradation on the guidelines which will be coming in, sir. So this particular molecule is there for because there's a lot of data which is around it, strong data. So I think thank you very much, sir, for the time
Okay.
which you have spent with us. Thank you.
Thank
Have a
you.
great day,
Thank
sir.
you. Bye.
Bye, sir.
Thank
Thank you,
you.
ma'am. Thank you very much, ma'am.
Thank you.
Thank you, Seema. Good day.
Thank you,
Bye.
Tripti.
So nice to see you. So nice.
So with the permission, sir, can I conclude?
Yeah, please go ahead.
Thank you.